The conversation I am about to have with you is one that I have had hundreds of times in 17 years of practice, and one that I believe the healthcare system does not have nearly often enough. It is the conversation about whether a medical test is actually in your best interest. Most patients assume it is. Tests are ordered by doctors. Doctors are trained to help. Therefore, tests help. This logic seems sound, and in many cases it is. But it contains an assumption that does not hold for every test, for every patient, at every age. The assumption that finding something is always better than not finding it. After 70, that assumption breaks down for 5 specific routine tests. Not because finding things is never valuable. It sometimes is. But because the specific tests I am going to describe today have a pattern, documented in peer-reviewed research and acknowledged by major guideline bodies, of finding things that lead to harms greater than the benefit of the finding itself. My name is Dr. Smith. I have spent 30 years in family and geriatric medicine, caring for adults through their 7th, 8th, and 9th decades of life. And the 5 tests I am going to discuss today are tests that I would not have performed as routine screening on myself or my family members after 70, because the evidence, when you look at it honestly and in its totality, does not consistently support their routine application in this age group. I want to be absolutely clear about 2 things before we go further. First, this applies to routine screening in asymptomatic adults, people who feel well and have no specific concerning symptoms. If you have symptoms, chest pain, bleeding, neurological changes, a new lump, investigate promptly. None of what I say today changes that. Second, individual circumstances matter enormously. There are 70-year-olds for whom some of these tests are entirely appropriate. The conversation I am advocating for is not blanket refusal. It is informed, individualized decision-making with your physician. The 4 questions I will give you at the end of this video are designed to support that conversation, not replace it. Leave your age in the comments. And tell me, has a routine test ever led to a procedure or a treatment that you wished, in retrospect, you had not had? Your experience will resonate with more people than you know. The logical foundation for everything in today's video can be expressed in a single question that medicine asks too rarely. Does this test, for this patient, at this age, in this health context, produce more benefit than harm? For many tests, for many patients, the answer is yes. But the answer changes with age, and it changes for 3 specific reasons. Reason 1, the time horizon problem. Medical screening produces benefit over time. You detect a condition early, you treat it, and over the following 10 to 15 years you avoid the harm that late-stage disease would have produced. This time horizon is well established for most screening benefits. But for a 76-year-old, a 15-year benefit horizon is not always realistic. For a 78-year-old with multiple comorbidities, a 10-year benefit horizon may not be realistic. When the patient's realistic life expectancy is shorter than the time frame over which the screening benefit accrues, the benefit never arrives. Only the harm of the cascade does. Reason 2, the competing risk problem. In older adults, multiple health conditions typically coexist. Even if a screening test identifies something, an early cancer, a carotid stenosis, an osteoporotic spine, the condition detected frequently competes with other conditions for clinical priority. A slow-growing prostate cancer in a 77-year-old man with established heart failure is far more likely to be eclipsed clinically by the heart failure than to become the dominant health threat. Treating the prostate cancer with surgery or radiation in this context exposes the man to treatment side effects while addressing a condition that was never going to be his primary problem. Reason 3, the amplified cascade. Every step of a diagnostic cascade, every biopsy, every catheterization, every surgery following a positive screening result, carries procedural risk. That risk scales upward with age. In older adults, the cumulative risk of a cascade is substantially higher than in younger adults who begin the same cascade from a starting point of greater physiological reserve. A complication that would be managed without difficulty in a 55-year-old can be life-altering or life-ending in a 78-year-old. These 3 reasons, the time horizon problem, the competing risk problem, and the amplified cascade, are the framework through which each of the 5 tests must be evaluated. And when they are, the case for routine application after 70 becomes significantly weaker than the standard scheduling protocols imply. Test number 1, Routine colonoscopy after 75. The U.S. Preventive Services Task Force, which issues the most rigorously evidence-reviewed screening guidelines in American medicine, explicitly recommends that the decision to perform colonoscopy in adults aged 76 to 85 should be individualized, and that screening adults over 85 provides no net benefit. This is not a minority viewpoint. It is the established guideline position based on a careful analysis of the evidence. Even assuming colonoscopy finds a small adenomatous polyp in a 78-year-old, which it frequently does, the time for that polyp to progress to invasive cancer is typically 10 to 15 years. In a 78-year-old with average health status, the realistic window within which that progression would become clinically significant often exceeds their life expectancy. The polyp is removed. The patient has an ongoing colonoscopy surveillance schedule. Years of follow-up occur for a condition that was never going to cause harm. Bowel preparation in older adults, particularly those on multiple medications affecting fluid and electrolyte balance, those with heart or kidney disease, and those with reduced functional reserve, is medically significant in a way that it is not in younger adults. Severe dehydration, electrolyte disturbances, falls during the preparation night, and medication interactions with preparation agents all occur at higher rates in older adults. The preparation is the highest risk component of the procedure for many elderly patients before the scope is ever inserted. If a finding requires biopsy, polypectomy, or follow-up, and in older adults, findings often do, the cascade from a routine colonoscopy may extend across multiple procedures, multiple sedation events, and multiple preparation events over months. Each carries its own risk profile in an aging body. A 77-year-old man in my practice, independent, socially active, driving himself to appointments, underwent a routine colonoscopy scheduled as a 10-year repeat from a normal prior study. During the procedure, a polypectomy was performed. He developed post-polypectomy bleeding 3 days later, a recognized complication requiring emergency hospitalization. He received blood transfusion, spent 5 days in hospital, and required a further endoscopy to control the bleeding. He was discharged on iron supplementation and never returned to his prior activity level. The polyp removed was a small tubular adenoma with low malignant potential. What to ask instead? Fecal immunochemical testing, annual stool testing, as a lower-risk alternative that detects significant pathology without procedural risk. Test number 2, aggressive breast and prostate screening. The USPSTF recommends against PSA-based prostate cancer screening in men 70 and older. The recommendation grade is D, meaning the organization has determined that the harms of screening outweigh the benefits in this population. This is not a cautious advisory. It is a clear recommendation against routine screening. For breast cancer, the USPSTF acknowledges that the evidence for mammography benefit in women over 75 is insufficient, a conclusion based on the absence of adequate trial data in this age group and the growing evidence for overdiagnosis in older women. The landmark European randomized study of screening for prostate cancer found that for every man whose death was prevented by PSA screening, approximately 27 men were overdiagnosed, found to have cancers that would never have caused them harm, but that were treated with interventions carrying significant side effects. In men over 70, the overdiagnosis ratio is even less favorable because the competing risks of other age-related conditions are higher and the window within which a slow-growing prostate cancer would become clinically significant is narrower. Radical prostatectomy in men over 70 produces permanent urinary incontinence in approximately 30 to 60% of patients and permanent erectile dysfunction in the majority. Radiation therapy produces radiation proctitis, bowel inflammation, and radiation cystitis, bladder inflammation, that significantly impair quality of life in older men. Androgen deprivation therapy, hormone therapy, produces bone loss, cognitive changes, fatigue, hot flushes, and cardiovascular risk over the treatment period. These are real harms. They are not rare, and they are being experienced by men whose cancers, had they never been screened, would never have caused them any problem. A 72-year-old man I knew, physically active, recently retired, planning to travel extensively, had a routine PSA test at his annual physical. The result was elevated. Biopsy confirmed intermediate-grade prostate cancer. He chose radiation. During and following radiation, he developed radiation proctitis, significant bowel urgency, and incontinence that persisted for 2 years. He could not travel. He could not engage in the activities he had retired for. His cancer, at 72, was extremely unlikely to have been his cause of death given its grade and volume. The treatment for it defined the quality of his early retirement years. What to ask instead? A frank discussion of what you would do if a test is positive before agreeing to screening. If aggressive treatment is not something you would choose, the case for screening that may lead to it deserves careful examination. Test number 3, routine cardiac stress testing. In asymptomatic older adults, the population in whom routine stress testing is frequently performed, the pretest probability of significant coronary artery disease causing the positive result is low. When pretest probability is low and the false positive rate of the test is high, the majority of positive results are false positives. Research consistently documents false positive rates of 30 to 40% in low-risk, asymptomatic populations undergoing nuclear or electrocardiographic stress testing. A positive stress test almost inevitably leads to cardiac catheterization. In older adults, catheterization carries risks of contrast-induced nephropathy, kidney injury from the iodinated contrast used during the procedure, more severe in aging kidneys, access site bleeding, from the femoral or radial artery puncture, cerebral embolism, from catheter manipulation in atherosclerotic vessels, arrhythmia, triggered by catheter contact with the cardiac conduction system. If catheterization finds a significant blockage, the clinical pressure to stent it is substantial, even in the absence of symptoms. The ischemia trial, a major contemporary randomized trial, found that invasive management of stable coronary artery disease produced no significant improvement in clinical outcomes compared to optimal medical therapy alone. Stenting a stable, asymptomatic lesion found during a cascade triggered by a routine stress test does not produce the benefit that most patients assume it does. In a 75-year-old with diabetes, arthritis, and mild heart failure, whose physical activity is genuinely limited by joint pain and breathlessness, a nuclear stress test that reveals impaired perfusion in a coronary territory is finding something that the patient's medical therapy may manage just as effectively as any intervention. And the cascade toward intervention carries risks that the therapy does not. A 73-year-old woman, active, independent, no cardiac symptoms, was recommended a routine stress test by her cardiologist as part of her annual cardiac review. The pharmacological stress test was abnormal. Catheterization was arranged. During the catheterization, a 75% blockage was identified in the left anterior descending artery. A stent was placed. She was discharged on dual antiplatelet therapy. 6 weeks later, she was admitted with a subdural hematoma, a brain bleed, precipitated by a minor head bump on the edge of a cupboard door. The antiplatelet medication that prevented her stent from clotting prevented her brain from stopping bleeding. She spent 3 weeks in a neurosurgical unit. What to ask instead? Cardiac investigation when symptoms develop: chest pain, dyspnea on exertion, palpitations, syncope. Not routine scheduling in asymptomatic adults. Test number 4, routine bone density DEXA scans with medication follow-up. Long-term bisphosphonate use. The standard pharmacological response to a low DEXA scan result is associated with 2 specific harms in older adults that are not adequately communicated at the point of prescription. Atypical femoral fractures associated with long-term bisphosphonate use are estimated to occur in approximately 1 per 1,000 patient years of treatment beyond 5 years. These fractures occur with minimal or no trauma, sometimes simply while walking, and require surgical fixation. In an 80-year-old, surgical repair of an atypical femoral fracture carries the same perioperative risk as hip fracture surgery. The fracture of the bisphosphonate was prescribed to prevent. Medication-related osteonecrosis of the jaw occurs in a small but significant proportion of patients on bisphosphonates who undergo dental procedures, tooth extractions, implants, periodontal surgery. The incidence increases with the duration of bisphosphonate use and the complexity of the dental procedure. In older adults for whom dental health is already a significant concern, Adding bisphosphonate jaw risk from a medication prescribed for a DEXA finding is a quality-of-life trade-off rarely presented transparently at prescription. Research consistently shows that in adults over 75, fractures occur primarily through falls, not through bone fragility alone. A fall prevention program, balance exercises, lower limb strengthening, medication review, home hazard assessment, vision correction, reduces hip fracture incidence more significantly than bisphosphonate therapy in this age group. And fall prevention produces no paradoxical fractures and no jaw complications. A patient in my practice, 81 years old, on bisphosphonates for 7 years following a DEXA scan showing osteoporosis, presented with thigh pain that had been attributed to arthritis for 3 months. X-ray revealed a bilateral atypical femoral stress fracture, the classic bisphosphonate complication. She required bilateral intramedullary nail fixation surgery. Recovery took 6 months. She had never fallen. She had never had a traumatic fracture. The medication prescribed specifically to prevent fracture had produced one through a separate mechanism. What to ask instead? Balance training, lower limb strengthening, medication review for fall risk contributors, vitamin D assessment. These are the evidence-based fracture prevention priorities for adults over 75. Test number 5. Routine carotid artery ultrasound in asymptomatic adults. The USPSTF currently holds a Grade D recommendation against screening for asymptomatic carotid artery stenosis in the general adult population, including adults over 70. A Grade D recommendation is the strongest recommendation against a practice that the USPSTF issues. It means the organization has determined that the harms of the screening clearly outweigh the benefits in the general population. Carotid endarterectomy, the standard surgical treatment for significant carotid stenosis, carries a perioperative stroke and death risk of approximately 2 to 3% across published series. In older adults with greater comorbidity burden, more fragile vasculature, and reduced physiological reserve, this risk is at the higher end of the range. The annual natural history stroke risk of asymptomatic carotid stenosis managed with optimal medical therapy, statins, blood pressure control, antiplatelet medication, is approximately 1 to 2% per year. For many patients, the perioperative surgical risk therefore equals or exceeds the annual natural history risk, meaning surgery confers no overall benefit when the cumulative risk curves are compared. And the patients who are most at risk from surgery, older, frilier, with more comorbidities, are precisely the patients in whom the perioperative risk is highest and the natural history risk is lowest relative to that surgical risk. If optimal medical therapy, statins, blood pressure control, antiplatelet medication, is the evidence-supported management for asymptomatic carotid stenosis regardless of the degree of stenosis found, the scan adds no treatment-directing information in most patients. The management is the same whether the scan is positive or negative. The only thing the positive scan adds is the pressure towards surgery that carries the risks I have described. For an 80-year-old in whom carotid endarterectomy is performed, a significant neck surgery under general anesthesia, the benefit of stroke prevention accrues over 3 to 5 years following the procedure. The perioperative risk is immediate. In older patients with limited life expectancy or significant competing health conditions, the benefit may not be realized before the competing risks of age and comorbidity determine the outcome. A 76-year-old woman, no neurological symptoms, no TI history, had a carotid ultrasound at a community cardiovascular screening event. A 75% stenosis was found in her right internal carotid artery. She was referred to vascular surgery. Endarterectomy was performed. During surgery, she developed intraoperative hemodynamic instability. She woke from the procedure with confusion that took 2 weeks to resolve, a hypoperfusion injury from the period during which the carotid was clamped. She was left with mild cognitive changes that persisted at 1-year follow-up. She had been neurologically normal before the screening event. The screening that identified her stenosis had been performed specifically to prevent the neurological harm that the treatment of the stenosis produced. What to ask instead? Symptom-driven investigation for anyone who has experienced TI, amaurosis fugax, or focal neurological symptoms. Optimal medical therapy for all cardiovascular risk factors as the standard of care regardless of what a scan would show. And a clear-eyed question to your physician. Would your management change if this scan found significant stenosis? Here is the practical tool I want you to carry into every medical appointment where a routine test is recommended. Question 1. Would my management change based on this result? If you would have optimal medical therapy whether the scan is positive or negative, the scan adds no treatment directing value, only anxiety and cascade risk. Question 2. Does the evidence for benefit from this test include patients of my age? Ask specifically. Many landmark trials studied adults aged 50 to 65. The extrapolation of those findings to 75 and 80-year-olds is often assumption rather than evidence. You deserve to know which category your test recommendation falls into. Question 3. What is the false positive rate? And what would the cascade from a false positive look like? Before the first test, trace the pathway to its end. What happens if it is positive? What happens if that follow-up is positive? Where does the cascade end? And what does each step carry in terms of procedural risk? Question 4. If I decline this test today and monitor for symptoms instead, what is the realistic risk of that decision? The risk of not screening is often lower, sometimes dramatically lower, than the risk of the cascade that a positive screening result initiates. Ask for an honest estimate of both before deciding. I want to end this section with complete clarity about what today's video does and does not say. It does not say that medicine is harmful. It does not say that doctors cannot be trusted. It does not say that all testing after 70 is dangerous or unnecessary. It says that 5 specific routine tests, in the specific context of asymptomatic screening of adults over 70, have documented harm profiles that are not adequately communicated to the patients who undergo them, and that those patients deserve the information I have shared today before they make their decisions. Active symptoms change everything. A new symptom in an adult over 70 deserves prompt, thorough, appropriate investigation. That is not what today's video is questioning. What today's video is questioning is the automatic, protocol-driven application of screening tests to adults who feel well, without adequate adjustment for age, for life expectancy, for competing risk, or for the cascade that a positive result will initiate. The difference between those two categories is the difference between medicine in service of the patient and medicine in service of the protocol. 30 years of caring for adults in their 70s, 80s, and 90s has taught me one thing above all others. The quality of the years matters as much as the number of them. And the test we perform in pursuit of extending the number can, when not carefully selected for the specific patient in front of us, diminish the quality of the years already available. I have watched patients lose 6 months to a cascade triggered by a colonoscopy that found a polyp that would never have caused them harm. I have watched men spend their early retirement years managing the side effects of prostate cancer treatment for a cancer that was never going to be their cause of death. I have watched a woman wake from a carotid surgery that was performed to prevent stroke with a neurological injury caused by the surgery itself. These are not cautionary tales I invented. They are the accumulated experience of 30 years of watching what happens when the screening system is applied to older adults without adequate consideration of whether the benefit of finding something outweighs the harm of the cascade that finding initiates. You deserve better than that. You deserve to be an informed participant in the decisions about your own medical care, not a passive recipient of whatever the protocol schedules. The 4 questions I have given you today are your tools for that participation. Use them at every appointment where a routine test is recommended. Ask them clearly. Expect a clear answer. And if the answer does not satisfy you, if the evidence for benefit in your specific age group is unclear, if the management would be the same regardless of the result, if the cascade from a positive result is more dangerous than the condition being screened for, you have the absolute right to decline. Leave a comment telling me your experience with any of the 5 tests I described today. Has one of them led to a cascade you wish you had questioned more carefully before it began? Your story is important, and sharing it here may be the most valuable contribution to this community you can make. If this video gave you something genuinely useful, please hit like. Share it with someone over 70 who deserves to have this conversation before their next routine appointment. And share it with their adult children who help navigate these decisions. Subscribe for weekly evidence-based, patient-centered content on healthcare decisions for adults over 70. The kind of content that puts your interests, your quality of life, and your right to informed consent at the center of every conversation. Your body, your years, your decision. Make it an informed one.